Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Feel free to ask questions in the chat box as we go along and they'll be addressed. So today we're going to be kicking off our clinical pathology month with Dr. Chima. She is a clinical assistant professor of medicine at the University of Maryland School of Medicine. Her specialty and as a board certified internist. She'll be providing her insights throughout our session and also today as we go over different pathology principles that are very, very important for the basis of disease. So remember, pathology is the basically defined as the way or physiology behind disease, and I'll sort of make correlates and connections between how exactly these basic fundamentals can lead up to the clinical foundation of knowledge. So Dr. Chima, if you don't mind kicking it off for us, thank you so much.
Good afternoon, everyone. Thank you, Minahil. I really appreciate. So, as Minahil mentioned, we are going to learn about the physiological adaptation, cellular injury, and then we'll discuss some case studies. So, I will talk very briefly about what is adaptation. So, basically, it's an internal body process to regulate and maintain the homeostasis for an organism to certain stimulus so they can exist in the environment. So that's how we need to have some adaptation. So we learn about, and first of all, from a physiology standpoint, is the normal cell, then adaptation, then cellular injury. So how we adapt in a situation of stress, and then a cell injury happens when there is some injurious stimulus there. So we're going to talk about it briefly, and then we'll go over the case studies. And again, like what are the adaptations, like temperature regulation, like some release of some toxins. So these are some examples. And before we move forward, as you know, we pretty quick talk about the self-care. So self-care doesn't mean that this means that we are selfish, that we have to care ourselves. No. The reason I always talk about the self-care because a medicine profession or healthcare profession is very rigorous process. From pre-medicine, your MCAT score, then you go to med school, then you go to the USMLE exams. So these are really a rigorous process, and we have to take care of ourselves so we can achieve our goals and fulfill our responsibilities, and we can help others. So self-care, again, 4 domains. I will talk pretty quick. It's physical health, PQ, IQ, mental health, spiritual health, and emotional health, EQ. So we need to work all these 4 areas to keep ourselves healthy. And physical health has, again, 4 domains. I make an acronym for it. S for sleep hygiene, E for exercise, L how to learn a daily basis, stress management, and F for food. So always add nutritious food. So self, SELF. Okay, this is for physical health. So I will stop here, and then of course I talk about in the previous sessions about the IQ, EQ, SQ as well. And then when we have a purpose of life, we keep ourselves motivated to achieve our goals. So I will stop here, and we have a very astute medical student with us, and I will request her. So let's go over briefly because it's a very basic mechanism we need to learn. And based on that, we have our basis, and then we can learn what is physiological adaptation, what is cell injury, and then we'll discuss the case studies. I'll stop here, and I'll request Minahil to please take over. Thank you.
Thank you so much, Dr. Chim. I really appreciate it. I know I love learning about self-care. It's always important to have reminders for us and really keeping that in mind as we go through these studies because, of course, it's a marathon, not a sprint or a race. So, right. So I know we talked a little bit, gave you guys a little bit of an overview of what we're going to be going over today. So again, we're going to start off with something called physiological adaptations or normal adaptations that the cell goes through, cellular injury, and then we'll have case studies. So let's start off with growth adaptations. And what that really means is basically, well, before I say that, first we need to consider what is actually physiologically normal. What is considered that? Usually it's there's this buzzword thrown around homeostasis. I know that is something I learned back in high school. We want to stay in homeostasis. That was like a vocabulary word in my AP biology, freshman biology classes. So basically, an organ is in homeostasis or physiological balance when the normal or physiological stress is placed on it. Now, physiologic is just another word of normal. Of course, we're always going through different stresses in our cell and our inner workings of our cells. So basically, from the macro level, we can consider that a normal physiologic stress is like, let's say our temperature, our normal body temperature is 98.6 degrees Fahrenheit. That means that our body that is the textbook definition of body homeostasis. Also having vitals within normal range. So having the respiratory rate at 18, that's the textbook normal respiratory rate, or a heart rate between 60 to 100-ish, or 60 to 90. So these are all examples of physiologic normality. So also, when you think about oxygen saturation, should be above at least above 93%, preferably between 96 to 100% O2 sat. I'm sure you've heard that as well. So these are all examples of homeostasis. Your body is working normally. And remember, we are made of cells. So let's now delve into the microscopic level of our cells. So for example, a cell is in homeostasis if its membrane is intact, if it's having its normal, we've all learned about protein transport in our cell biology classes in undergrad. We learned about how the Golgi body transports or packages proteins as well. So remember all these processes, we're always learning again and again about DNA, transcription, translation of from ribosomes making our proteins, and then transporting those proteins. Why do we have proteins? So all these processes need to be done normally under a normal physiological pH environment, have enough oxygen. So if we don't have oxygen, let's say, and we're under hypoxia, that is affecting our cells. It's not just our bodies, or I can't breathe, or let's say if I am under dyspnea or having difficulty breathing, there's a cellular reason why I'm having trouble or difficulty breathing. It's because my cells aren't getting enough oxygen that they need. So again, the organ is in homeostatic balance with the normal physiologic stresses based upon it. I hope that makes sense. And also remember that an increase, decrease, or a change in stress on an organ, remember organs are made out of cells. So remember, I remember learning this in like middle high school. We learned that basically we are humans. We are made of, like, you could say, our skin is an organ. So I used to think of it as cells. We start off in the smallest level. Cells make up tissues. Tissues make up organs. Organs make up organ systems. Organ systems make up the organism, or the human itself, right? So now we're just going to look. So if an increase, decrease, or a change in the stress of a cell or on an organ, it can result in growth adaptations of the cell itself. All right. That should be that. And now this is a really interesting graph, and I'm going to revisit it again. But basically, look, an increase, decrease, or a change in stress of an organ can result in growth adaptation. So let me get my pointer here. Let me find my pointer, because I want to be able to draw. Let's see, annotate. Oh, here we go, found it. Okay, so let me get out my arrow. Okay, well, we can just go by my cursor. Can everyone see my cursor? Yes? Okay, great. So basically, we have our normal cell here under homeostasis. Again, we talked about what homeostasis means, being a normal, physiologic, healthy cell. But if there is stress or increased demand, now this type of stress can take the form of many different examples. Before I gave an example of hypoxia or low oxygen, there could also be acid buildup. There could be a radical oxygen species being produced, leading to higher acidity in the cell. So, and that leads to increased demand, or the cell just needs to work a little bit harder to maintain or try to come back to homeostasis, because ultimately the cell is trying to reach this top portion. And if there is stress, the cell will adapt and then try to return back to normal homeostasis, normal cell. So I can draw that actually like this. So if it's able to adapt, it'll return to a normal cell. That's its goal, right? That's why it's adapting, so that it can hopefully return. There are reversible and irreversible adaptations that we'll go over. But if it is unable to adapt, if the cell is not able to adapt, then that can lead to cell injury or cell death. Now, normal cells can also go directly into cell injury or cell death if there is a stimulus. Like let's say I cut my hand while cutting onions. So that would lead just immediate cell injury or cell death, right? My cells would not have had enough time to adapt to that type of trauma. So let me try clear all drawings. There we go. Clear all drawings. All right, let me go back and let me continue on. Okay, so these are different types of growth adaptations that you see here. So we'll go over them one by one. So let's start off with hypertrophy and hyperplasia. On the top and the left. So one might think that hypertrophy and hyperplasia are the same. They're both hyper, so you might think there's more. But really, an increase in stress leads to an increase on organ size, or an organ size, basically. Essentially, like both hyperplasia and hypertrophy can work together, but essentially, like there is increase in size, which means hypertrophy. Hypertrophy is the opposite of atrophy. Atrophy means decrease in size or the number of cells. So there could be an increase in the number of cells. That is called hyperplasia. So hypertrophy and hyperplasia are not the same thing. They are different because hyperplasia is an increase in number of cells, and hyperplasia is an increase in size of the same cells itself. So there aren't increased number of cells. Hypertrophy involves gene activation, protein synthesis, in order to increase that cell size, and also the production of more and more organelles. And hyperplasia involves the production of new cells from stem cells. We have a lot of baseline stem cells, and so these stem cells can differentiate into any different type of cells. So if I do need a new number of cells, not every organ in the body can undergo hyperplasia. For example, the heart, cardiac myocytes do not always necessarily regenerate. That's just like a basic fundamental knowledge. Of course, there's always exceptions to the rule, but cardiac myocytes in general, once a tissue is dead or cell death, it cannot regenerate new cells unless you do like a. Now, of course, there are different stem cell therapies nowadays. When I'm talking about a healthy, normal functioning heart, can we reform a new heart in case I have like a heart attack or myocardial infarction, and I have some like let's say a part of a ventricle is dead or not pumping properly. I don't have stem cells there naturally produced in the heart to be able to undergo hyperplasia, but the heart can undergo hypertrophy. But generally, hyperplasia and hypertrophy generally occur together. For example, the uterus during pregnancy, it undergoes both hyperplasia and hypertrophy. And this is an example of physiologic adaptation, right? But permanent tissues, like I said before, cardiac muscle, skeletal muscle, nerves, cannot make new cells, and they undergo hypertrophy only. That's an important concept to remember. And I can repeat it again because it is so important. For example, the brain, nerves cannot form again, cardiac muscle cannot form again, and skeletal muscle cannot form again from stem cells. It can only undergo hypertrophy or atrophy. It cannot undergo hyperplasia. So for example, if we have like, I can go over that later, the examples. Now hyperplasia, like I said before, is the concept of having an increase in the number of cells. An example of hyperplasia, like I said before, pregnancy, the uterus increases in size, and we'll go over a couple more examples in depth. We also have atrophy. Atrophy just means basically a decrease in the number of cells or cell size. Now, you can get into specifics. This is from Amboss, where they differentiate cellular atrophy or hypotrophy, which basically means a decrease in cell size or a decrease in cell number. Either way, you have the same. Either way, the cell is decreased, or the organ itself will decrease, right? At the macro level, you're decreasing in size. Now, you don't know whether it's because you're decreasing number of cells or decreasing number of cell size until you do a little bit more of a further investigation. Same with the organ when it's undergoing hypertrophy or hyperplasia. Either way, the organ is increasing in size overall, but you need to differentiate between is the increase in size caused by the cells themselves growing, or is it caused by the number of cells growing, regenerating? And finally, we also have metaplasia. Metaplasia really just means a change in cell type. So we can go from a specific type of squamous cell epithelium to, let's say, stratified cuboidal epithelium. So this is a classic example of how our cell types can also change as well. So maybe that you've heard of a disease where basically instead of regenerating new skin, you regenerate more bone in place of skin. So that is one type of metaplasia and a change in cell type. So now let's go over one by one, examples of hypertrophy, which means an increase in cell size and increase in cell size. So hypertrophy, physiologic means normal. So let's say you're a bodybuilder or an athlete. Now remember, I said before, skeletal muscle or muscles cannot don't have stem cells to increase and go into hyperplasia. But muscles can undergo hypertrophy if you keep exercising, keep using them. So for example, a non-athlete, such as myself, would have a skeletal muscular composition that looks like this under a microscope, whereas an athlete would have bigger cells because they have more muscles. So that's why you'd see bodybuilders, clear, when you think of a bodybuilder, you think of their muscles or their muscular appearance. They're much bigger, you could say, in body composition. And also uterine hypertrophy, like I mentioned before, during pregnancy. We're not increasing in a number of cells, we're increasing the cell size. Now, they also undergo, the uterus also undergoes hyperplasia. And also pathologically, or something that would cause a disease, a basis of disease, pathologically, if you have systemic hypertension, now remember, hypertension just means an increased blood pressure. So there's increased pressure, your heart muscle is working harder and harder to pump that blood, and that could lead, or it could be caused by atherosclerosis if you don't have very good diet, or if you have something in your genes. That leads to arteries getting clogged, basically with plaque, or you could have a myocardial infarction, which is another word for heart attack, caused by atherosclerosis or a thrombus in your ventricles of the heart, and it can lead to pathologic hypertrophy, which could lead to, like, let's say, because your heart muscle is working so hard to pump out blood, it would lead to hypertrophy in the cardiac muscle. So you can see here on the left, you see left ventricular hypertrophy versus a normal heart. Now these are just taken out of actual bodies. It's not from a live sample, whereas on the right, you could see that this could be either a biopsy, but if you don't necessarily there are other ways to diagnose LVH, or left ventricular hypertrophy. But you can see here the systemic hypertension if you are in a cadaver lab and you are looking at someone's heart who had passed away due to systemic hypertension or poorly controlled hypertension, and you take out their heart and look at it, you can see that their left ventricle is much bigger because it had to work much harder, and as a result, it can lead to different clinical manifestations and symptoms. Now, hyperplasia, on the other hand, is the increase in cell number. Physiologically, the breast actually undergoes hyperplasia during pregnancy, lactation, and also puberty, which means increase in cell number, not cell size. Or lactation, if you are producing milk, the breast lobules increase. And also, there's something called uterine hyperplasia as well during pregnancy. And I said before, it can the uterus goes through both hyperplasia and hypertrophy during pregnancy. And a pathologic example of hyperplasia includes endometrial hyperplasia. These are two different, basically these are cross sections of tissue under a cell slide. So after it goes through like a process. Now pathologists are the ones looking over these types of slides in order to diagnose different things. So let's say you took a biopsy or a piece of the endometrium, and you look at it under a microscope after it's all processed and it's formalin, etc. You can compare the normal endometrium. You can see the glands here are a little, these are basically the glands you want to look at. And there's an increased number of glands in the orange arrow here when there's endometrial hyperplasia. It's caused by an increase in progesterone. So basically glands tend to have hyperplasia occur. That's why the breast lobules increase in size, because it's technically a gland. They increase in size because of the different, now glands are influenced by hormones, and hormones such as progesterone. If there's a pathologic increase in progesterone, it can lead to endometrial hyperplasia, which can lead to different types of cancers. So yeah, there's an increased number of glands, as you can see here. Here, this is just one gland represented by the entire area, that white state, that is one gland. But here you can see many more glands. That is not normal. Okay, and I said this before, and I want to reiterate it again, that hyperplasia and hypertrophy often occur together, but they are separate processes. Now, ultimately, your end result is the same, but you do need to be able to differentiate, because glands undergo more hyperplasia rather than hypertrophy, whereas hypertrophy occurs in the muscles that cannot regenerate stem cells, right? So, for example, the skeletal muscle, the cardiac muscle, and nerves, or in the nervous system. All right, now let's go over atrophy, which is our next type of cellular adaptation. Now, atrophy is a decrease in cell number or size. So I sort of lump them together, even though different sources can call it numerical atrophy or hypoatrophy, but ultimately it's a decreasing number of cell number or size. And physiologically, you see this. So basically, when we are in utero, in the womb, we have webbed fingers as embryos. So actually, there's apoptosis that occurs to formulate the 5 digits to be healthy. Sometimes it does not occur, and that will lead to a pathology. But right now, we're talking about normal physiological. It's normal to have atrophy occur, to be able to have webbed fingers, to be able to have separated fingers. And if it doesn't occur, it would lead to webbed webbed fingers. So you lose these structures during your development in utero. Another example is breast involution, which basically means when the breast stop when let's say a mother no longer is breastfeeding for whatever reason, or after a couple of years when the mother stops breastfeeding her child, then there's less need and less hormones that are produced as a result, and that would lead to an involution in the breasts, which would decrease the amount of lactation, right? Because women are not always lactating when their children no longer need it. So I think that's amazing to think about. And also menopause. Menopause can be considered pathologic as well, but it is a normal process of aging. And so menopause also leads to the decrease in the size of the ovaries when women are no longer menstruating, when they hit that age of in their mid 50s or late 40s. Now, an example of pathologic atrophy is dementia. Now, why is it pathologic? Well, one reason is because the brain cannot regenerate these nerve cells or the neurons, right, in the brain. So let's say someone has dementia or Alzheimer's, and you compare their brain, a normal person's brain, to a patient's brain with dementia. You can see here that the cortex is shrunk. It's much, much smaller than someone who does not have dementia or a healthy brain. So again, that's atrophy, an example of atrophy. And finally, ischemia is also leads to an atrophy of tissue over time. So let's say someone needs CPR, undergoes cardiac arrest, or let's say they need to be intubated, or they're just all of a sudden they stop breathing, and that's called a blue code because the patient turns blue. The reason why is because if you do not use it, you lose it. So let's say you stop breathing, that can, or because of ischemia, you stop. Let's say I close my nose right now and I stop breathing. If I stopped breathing for more than like 30, 40 minutes, tissues will atrophy. I will not be able to recover unless I already had a dose of oxygen given to me by the time I run out of air, right? Or by the time my body runs out of oxygen. Every single cell in your body needs oxygen. I'll explain that a little bit later. And also muscle disuse. So when you're thinking about, let's say you're laying down in your bed for like a week at a time. Now, this is not recommended at all to do at home, but let's say you do, hypothetically. You will notice, or actually, let's just give an airplane example. Let's say you're in the airplane for 14, 18 hours. Let's say you're taking the longest airplane ride ever from, let's say, LA all the way to Singapore, from the longer way, not from the shorter way, across the Atlantic Ocean, not the Pacific Ocean. And if you choose to do that and you're sitting for a long period of time, this is why they actually recommend having basically the socks to help prevent that from happening, or getting up every 30 minutes when you're studying, because if you do not use your muscles, you will have trouble getting up and walking again after just 18 hours of just straight sitting. And it is reversible. We know that this is reversible. I know that I've had long plane flights. I'm not able to walk for the first few minutes, but as I use my muscles again and activate them, I'm able to reverse that very slight muscle atrophy I might have had, or let's say I was sick for 2, 3 weeks, and got deconditioned in the hospital. I can recover that because my muscles can undergo hypertrophy again and basically return back to baseline or normal. Now we're going to watch this video about metaplasia, but before I do that, and it's a little bit hard to understand, like this is something I had trouble grasping, like metaplasia. How can a cell change in its type? Does that mean that in my heart, anytime my heart cell can go turn into a brain cell? No, that's not actually what happens. Although it can, because technically all cells come from the same stem cell as they differentiate. But actually, I'll show you right now what exactly Barrett's is off. What exactly this example is of so basically I'll talk about it as we go along. I muted it on purpose. So let's say basically you have a stress. Now in this case, the stress placed on the body's physiological system is right now acid. And so if this acid keeps hitting your esophagus, it will change the type of cell over time. Essentially in this scenario, you can see here, this is the normal types of cells. Actually, no, that's when metaplasia occurs. So basically, this is the wrong type of cell. Well, not wrong type necessarily, but basically, this is what can happen to your body's cells. And they will change over time. And they'll change to these simple columnar or stratified columnar epithelium. They started off as stratified squamous epithelium, and it basically changes to that. Let me actually draw that and make it clear. So basically, I started off with stratified squamous epithelium, and basically my epithelium changes or undergoes metaplasia, metaplasia in order to, and that changed the cell type, right? Because before they were a little bit squishier, they were squamous epithelium, and it changed into simple columnar epithelium. Now, we might be, maybe some of us might not know, and I also had to look it up, like how to explain epithelium to people. Basically, let's look at our skin, for example. There is a lining. Right now I'm touching my epidermis. It is the outermost layer of my skin. Now, the epidermis is composed of an epithelium. Now, our organs are also, let's say if you're thinking about the stomach, it is also lined with epithelium, and also in the inside, right? Because these are 3D structures. So this is my esophagus. It is lined by epithelium on the sides. And so that epithelium or outer layering can change. And so these are different types of epitheliums that can exist and occur. Hope that makes sense. And basically, when a cell changes in type, it can turn into something called Barrett's esophagus. This is just one very classic example of metaplasia. Basically, this is the most common involvement is the changing of one type of surface epithelium, like squamous, columnar, to another. And so these metaplastic cells, they're better able to handle the new stress. That's why now this can be considered physiologic and borderline pathologic as well. That's why I didn't really differentiate them because it depends on the context. And so now you can see here the esophagus that's normally lined by the squamous epithelium. It's now the esophagus normally is able to handle the food bolus with more of a squamous epithelium type because there's a lot of friction from that food bolus. But if there's acid reflux coming from the stomach that's hitting the esophagus, it can cause the change in cell type called Barrett's esophagus into non-ciliated mucin-producing columnar cells because these columnar cells are better able to handle the new acid. And so if there's persistent stress, actually, this metaplastic change can actually change into dysplasia. And dysplasia is something we're going to be talking about in our next session when we talk about neoplasia, because dysplasia is actually termed precancerous cells. And metaplasia can lead to dysplasia, and dysplasia can not always, because technically dysplasia is also reversible, but this dysplasia can happen from metaplasia. Dysplasia refers to precancerous cells. So, for example, like Barrett esophagus, it can progress to adenocarcinoma of the esophagus. But there are some other examples of metaplasia, like the apocrine metaplasia of the breast, that carries no increased risk of cancer. There's another example I think I had here. Yes, metaplasia. Another example is vitamin A deficiency, which can also result in metaplasia. And vitamin A is really necessary for the differentiation of specialized epithelial services, such as like the conjunctiva of our eye. The conjunctiva is basically the covering, the outer layering of our eyes. And if we have vitamin A deficiency, the thin squamous lining of the conjunctiva undergoes metaplasia into the stratified keratinizing squamous epithelium. I know that's a handful, a wordful, if you will. But basically, this change is called keratomalacia. Keratomalacia. And you can see here, you can compare the left, basically this is the patient's right eye to the left eye. The patient's left eye has the keratomalacia. And I wanted to show different examples of keratomalacia, but these are all keratomalacia. And basically this is the change from the squamous epithelium to the cuboidal epithelium. That's what happens. And that's really amazing to think about, that vitamin A deficiency can lead to something like this. Because remember, vitamins, minerals, hormones, they're all over our bodies and used by different areas of our body. All right. I think, yeah. Oh, here we go. Dysplasia, the explanation of dysplasia. So dysplasia refers to disordered cellular growth. And this most often, like I said before, refers to the proliferation of precancerous cells. For example, I would say, for example, like there is, well, I know we talked about like it can happen from long withstanding pathologic hyperplasia, like the endometrial hyperplasia I talked about before. That can also lead to cancer, or metaplasia from Barrett esophagus. And in theory, dysplasia is reversible if the stress stops. With the alleviation of the inciting stress. But if the stress persists, dysplasia can progress to carcinoma. And actually, so an example of this is basically the pre-invasive changes in the bronchial epithelium of smokers, right? Because of the tobacco smoke, it's a carcinogen, as we all know. Smoking causes lung cancer, but how does it cause lung cancer? Over time, the carcinogens in the smoke of cigarettes, as someone is drinking or smoking cigars or cigarettes or however they are smoking, with nicotine, that nicotine is a carcinogen. Carcinogen is another word for cancer causing. That can lead over time. Smoking one time is not going to give you lung cancer, but over time is the issue. Smoking, smoking is not recommended at all to do, but since it is addicting, even starting at one time can lead to someone forming a habit and doing it over and over again. So it can lead to dysplasia of the bronchus, the bronchial epithelium. Remember, so the esophagus has an epithelium, the stomach has epithelium, our intestines have an epithelium, and also the bronchus. So the bronchial epithelium specifically gets affected because once you're smoking, it causes the reversible, at first it starts as reversal because if you stop smoking, if you're advised to stop smoking, you do stop smoking right before you do hit the lung cancer stage. Remember, cancer has stages, and this is something we'll talk about more and more in depth next time regarding neoplasia, but I'm just throwing that word out now so we can think about it a little bit. But basically, an example of dysplasia would be pre-invasive changes in the bronchial epithelium of smokers right before it becomes invasive or cancerous. And I did put a picture because I want to talk about this more in depth next week. But yeah, here are pictures actually. So you can see here, this is the normal mucosa. It undergoes hyperplasia because let's say if you're causing a stress or let's say scarring, for example, if I keep hitting myself with a knife, I'll eventually form thicker and thicker scars, right, on my wrist. Or if let's say I keep hitting the same spot when I'm cutting onions, then eventually it'll lead to let's say calloused hands. That is a different type of epithelium or skin type, you could say, because your body is trying to adapt so that it can stop getting stressed or harmed in an environment where it is being harmed. But let's say that also does not help with the stress alleviation. It will lead to disordered cell growth because the cells just are slowly turning into dysplasia or disordered growth. And you can see here that this is actually a progression. So from 1A, let me actually get my pointer. So I start off with 1A, the 1A panels. This is actually a healthy cell, you can say. 1B is actually after a couple, after a few smoking, a few carcinogenic exposures. And then this leads to 1C, which is the third panel here. You can see the cells over here are becoming more and more disordered. And 1D is when it becomes truly pre-invasive, because you can see here the cells are about to invade, right? That's just invasive. And leave this epithelium layer and go somewhere else, but not yet. This is dysplasia. If someone stops the exposure to the smoking hazard, technically speaking, this can be reversed once this can be reversed back to this, or maybe 1B. 1D can turn into 1B or 1A, as long as the previous smoker actually sort of stops smoking and has a better lifestyle changes. So I hope that makes sense, and a little bit of a description of what dysplasia is. I know it was a pretty long-winded, but I think it is important to remember that dysplasia is not cancer. Dysplasia is pre-cancerous, and that's why I wrote that here. All right. Now, again, I want to revisit this, like I said before. So basically, remember, the normal cell is under homeostasis. And I showed you the different types of adaptations. What are the adaptations? Remember, atrophy, hyperplasia, hypertrophy, metaplasia, and also dysplasia. So there's 5 total. But let's say the cell is unable to adapt. If it is unable to adapt, cellular injury occurs. Now, cellular injury occurs when a stress exceeds the cell's ability to adapt. So the likelihood of injury actually really depends on the type of stress that's being applied. So, and I can actually go on to next slide here. So you can see your cellular injuries as our next section. So that's a good segue into it. But basically, the basic principles of cellular injury according to Pathoma include, of course, when the stress exceeds the cell's ability to adapt, and the likelihood of injury depends on the type of stress, its severity, and the type of cell affected. So there are some cells that are much more susceptible than other cells to cellular injury because let's think again about the nervous system, the cardiac myocytes and the skeletal muscle cells. They're more likely to become injured. For example, neurons, they're highly highly susceptible to ischemic injury. Where that's why you need to have oxygen. Otherwise, if you become quote unquote brain dead as a result of not having oxygen in your brain for a long period of time, that's why drowning is so dangerous, because you need to have that oxygen. Your brain has the least, I would say, oxygen stores compared to the rest of the body. But once the brain does not have enough oxygen, it cannot lead the rest of the organs to keep functioning appropriately. So neurons are the most susceptible to ischemic injury or becoming hypoxic, whereas skeletal muscle is relatively more resistant. So skeletal muscle can undergo processes where it can undergo lactic acid fermentation and not need oxygen as much as the neurons do. But it's very important for neurons to have their oxygen. But like slowly developing ischemia, such as like renal artery atherosclerosis, also results in atrophy. Whereas acute ischemia, like a renal artery embolus, can also result in injury. So the most common causes, let me see if I have a slide for that. The common causes, yeah. So I wanted to ask you all actually, what do you think are the most common causes of cellular injury? So let me wait for a little bit for you guys to think about. Like I talk about hypoxia, that is a pretty common one, but there are others. I guess the hint here is this box here. If anyone remembers what this is see the citric acid cycle, I think the Krebs cycle, oxidative phosphorylation. So that's whenever I say like I was hinting at it in the beginning of the presentation, what I was sort of preluding to this, talking about why it's so important to have oxygen, because our mitochondria, remember almost every cell in our body has a mitochondria besides like red blood cells. But mitochondria, again, powerhouse of the cell. Why is it a powerhouse? Well, number one, it produces ATP, of course. But how does it produce ATP? It needs oxygen, because oxygen is the last electron acceptor in the oxidative phosphorylation chain, in the electron transfer chain. So this is why, I would be suffering, I would say, through my undergrad classes, learning over and over again the oxidative phosphorylation, taking it, like being tested on it during the MCAT, and again in the foundation modules of medical school when I first started out, because it's so crucial to remember. Why is oxygen important? Because it's the last electron transporter acceptor in the electron transport chain, in order to produce enough ATP for our cells to function and survive. So, the common causes of cellular injury include inflammation, nutritional deficiency or excess of nutrition, hypoxia, trauma, and also genetic mutations. So actually, now I'll go back here and talk a little bit about reversible versus irreversible cellular injury. So, like we said before, hypoxia impairs the oxidative phosphorylation, resulting in decreased ATP. Now, this is a chain of events. Now, think about it like a domino theory effect. Now, if I've decreased ATP, low ATP disrupts the key cellular functions, such as the sodium-potassium pump you may be remembering, leading to sodium and water building up inside the cell. The calcium pump, resulting in calcium buildup inside of the cell, inside of the cytosol of the cell. Then the aerobic glycolysis will result to switching to anaerobic glycolysis, and so lactic acid will build up. If lactic acid builds up, my pH will go down and become more acidic. So I'll have a lower pH. And that will denature proteins. Remember, I was talking a little bit about proteins, ribosomes, protein factories, transcription translation, making these proteins. Now, transcription translation works so hard, and ribosomes work so hard, our endoplasmic reticulum worked so hard to make our proteins. But if the proteins are not in the proper pH, remember homeostasis, if there isn't the proper pH that we need for these specific proteins, as a result of pathologic changes, there's low pH that can denature proteins, and it can also precipitate the DNA. If there's no DNA, then no proteins can be produced. Without proteins, we cannot ultimately function. So again, remember, the building blocks of proteins are amino acids. That's why we learn so much biochemistry and organic chemistry and general chemistry. Why does this all matter? It really does. Now, the initial phase of injury is reversible. That's the point I was trying to make. Now, the hallmark of reversible injury is cellular swelling. So if the cell swells up, that's technically a good sign. It's better than the cell doing something else I'll talk about. But basically, cytosolic swelling results in the loss of microvilli and membrane blebbing. So you'll see little blebs on the membranes. That's what you see in the graph here. But the swelling of the rough endoplasmic reticulum, as you can see on the left-hand panel, results in the dissociation of ribosomes and decreased protein synthesis. So cytosolic swelling is technically reversible. It can go back as long as the stress stops or ceases. Now, how do we stop stress? Well, there are different types of ways. This is why we look at a patient's clinical presentation. I mean, we give them medications to try to stop different types of stresses from occurring. Now, irreversible damage, eventually it can become irreversible if it's left untreated or if the stress continues. The hallmark of irreversible injury is membrane damage, because once that membrane pops, all the cytosolic contents will basically, organelles
Allah.
sorry, that's my call for prayer. As Muslims, we pray 5 times a day, so that was just the call to our prayer. But yeah, eventually, as I was saying before, the damage becomes irreversible, and the membrane damage. Once the membranes are damaged, remember how important the cellular membrane is. We learned about in plants, they have cell walls, and in animal cells, in eukaryotic cells, animal cells, we have cell membranes. We don't have cell walls. So technically, our membranes, while they are semi-permeable membranes, they are still membranous, and they keep our organelles intact. If our organelles can no longer be intact anymore, then all of our centers are affected. Our nucleus becomes exposed. Our mitochondria is no longer able to function. That's why our mitochondria is so crucial. Mitochondria has its own membrane, but if the mitochondrial membrane is not safeguarded by the overall plasma membrane of the cell, then that will also rupture and break, and everything just breaks apart. Basically, I just imagine like a cell explosion, basically. So plasma membrane damage leads to the cytosolic enzymes leaking into the serum. And that's why we use something called cardiac troponin to be able to tell if a patient has had a cardiac event, like a heart attack. That's what troponin is used for. It's actually a heart enzyme that if it's leaking into the blood serum, into the blood, that means that there was irreversible cell damage that occurred as a result of the like maybe let's say there's atherosclerosis that led to a heart attack, and that's why if the cardiac muscle, if one part of it is not working but the rest of it is, then it leads to the heart attack and the chest pain symptoms. And so it all connects, right? Everything we learned from high school all the way to medical school into the understanding of how this pathology occurred will help us treat it and manage it eventually. So it keeps coming back. And of course, another thing that happens when the plasma membrane is damaged, it leads to additional calcium entering into the cell. And also, I was talking about this before I was interrupted. Mitochondrial membrane damage results in the loss of the electron transport chain. Remember the inner mitochondrial membrane where that I showed you the oxidative phosphorylation. And also cytochrome C, that might ring a bell. Cytochrome C, that leaks into the cytosol, that'll activate apoptosis, which basically means programmed cell death. And that'll lead to eventual cell death, right? Another fun fact is, lysosomes, they're also another organelle in the cell. They're very important for storage, but lysosomes are also bound by inner membrane. And so if that lysosome membrane is also damaged, it leads to all the enzymes that are inside of that lysosome that are very toxic. It should not be outside of that cell or in the cytosol, or let alone in the rest of the body. That will lead to enzymes leaking into cytosol, which are activated by high intracellular calcium. So basically, if things are not where they're supposed to be because they're so specialized and packaged, it will lead to irreversible injury. And the end result of irreversible injury is cell death. So I'll leave that there. We talked a little bit about the common causes of injury. We can reiterate again, basically, where hypoxia, low oxygen delivery to tissue, right? That's an important cause of cellular injury. Because of that, oxygen being the final electron acceptor in the electron transport chain during the oxidative phosphorylation, there's a decreased oxygen. And if there is decreased oxygen, impairing the oxidative phosphorylation, it lead to decreased ATP production. Lack of ATP, which is an essential energy source, as we all know, it will lead to cellular injury. Now, remember, where does oxidative phosphorylation occur in the body again? The mitochondria. That's why I put that there. The mitochondria has an inner membrane, intermembrane space. All right. And of course, macroscopically, now if you want to look at the bigger picture, ischemia will also leads to decreased blood flow through an organ. That leads to decreased arterial perfusion, which is atherosclerosis. It can lead to shock, like generalized hypotension, resulting in poor tissue perfusion because there's not enough blood being flown in where it needs to be. If there's there'll also be hypoxemia, because if there's not enough, if there's no oxygen in our bloodstream either, our red blood cells get affected. That's why at high altitudes, it'll affect your ability to be able to process oxygen in your red blood cells. But that's another topic for another day. And basically, if there's decreased oxygen carrying capacity, it will lead to hemoglobin loss or dysfunction. Hemoglobin is very important in our blood, of course, and that'll lead to anemia, which is a decrease in red blood cell mass. It can also lead to carbon monoxide poisoning. So again, this is very, very, very a really key fundamental concept of clinical pathology. All right. So I did want to ask at the end as well, like which of these causes is the most common? It is hypoxia. So now that we're done going over all the different types of cellular adaptations and also what can happen during injury, I remember when I was first learning this, it was very overwhelming. We learned this in just a matter of, this is probably only one lecture out of 3 lectures on the same day. And then the next day, we were going to have more and more lectures. So I'm sure you've all heard of the fire hose analogy in medical school, where it just feels like you're streaming a fire hose into your mouth and trying to drink and swallow all that water. Now, I don't really like that analogy. I prefer to use an analogy called the pancake analogy, which basically means that, let's say you have 30 pancakes to eat per week. Now, you're not able to digest or eat all 30 pancakes normally, but you can eat 1 or 2 pancakes, and you are given 1 or 2 or 3 pancakes a day. Now, if you're consuming those 3 pancakes every day, you're fine. But if you wait till the end of the week, you'll have 30 pancakes to eat. And if you wait that long, it's really difficult to consume and understand and digest the material. Pun intended. So when I was studying this, I knew that I needed to get organized. So understanding that this is different from the molecular physiology, because I'm not being tested on oxidative phosphorylation again. I already understood that from my undergrad classes and the prerequisites to get into medical school. But really, understanding it in the context of clinical pathology, what I've done is I make charts like these. This is just how I learn. Now, you might be learning in a different way. People use mind maps, people use flashcards, people use all types of different things. Or they draw it out, they take notes, they make beautiful, beautiful drawings. I make disease charts. Basically, I basically split up, hypertrophy. I'm thinking muscle and brain. Those are, and also cardiac tissue. I should probably have had that in there. Hyperplasia, glands, atrophy, metaplasia, dysplasia. And this is how I sort of organized. This is exactly how my brain organized it in order to memorize it, because we need to have all of this memorized for exams, for tests, and also just to be better clinicians, because this serves as the foundation of the understanding of all diseases. So if we don't have a proper foundation to build upon different types of diseases like dementia or Alzheimer's or heart attacks, myocardial infarctions, or different causes of ischemia leading to different clinical manifestations, if I don't have a foundation that looks like this, my foundation is weak, I won't be able to understand the rest of the diseases. So this is just how I organize it in my head. And I went over all this to all of you guys in the last, I would say 30, 40 minutes or so. And so if you're able to understand what I've talked about through this presentation, you go over some other types of resources online that are available. If you just Google like cellular adaptations and growth worksheets, there are a lot of really good questions online. And of course, it's based on Pathoma's Chapter 1. Pathoma is an amazing resource that we use when preparing for USMLE Step 1 in our pre-clerkship curriculum, aka the first 2 years of medical school, when we're learning more book sciences, or we're more so learning the clinical knowledge needed in order to apply it in our 3rd and 4th year with our patients. All right, now we're going to switch gears into case studies, applying all the knowledge that we learned today into a little very basic clinical scenarios. But I think that it'll help sort of organize in your heads, like, why did I just learn all that? Why is that important? And where is it going to be applied? And and these will seem pretty random to you, but I have been hinting at them throughout the presentation. So before we get into case studies, I do want to go over these charts I've talked about before when talking about the practice of medicine. Now, I'm sure you've all heard of how, or if you may have served as a scribe in the past as well, or shadowed in person, seen doctors sort of gather information in very effective and systematic ways. And so this is sort of what I've adapted from another place. So basically, This is what I use personally when I'm talking to a patient, and I sort of refer to it to make sure I have everything down. So there's something called an HPI. HPI means a history of present illness. So of course I need to know, I need to confirm the patient's gender, age. I'll write down the room number if I need to, and what the CC is, chief complaint. DDX means differential diagnosis, or I usually do this at the end, right? The differential diagnosis after I've talked to the patient for a little bit. Let me just switch my color to pink so it's easier to see. And let me make my drawing pen a little bit thicker. There we go. So PMA, so basically an HPI includes is a part of something called a skill of history taking. Now, we spent a semester in medical school just learning how to perfect our ability to take histories. So in HPI, again, history of present illness. Now you think about it, this is not past medical history. This is what the patient is there for, presenting illness today. What are they presenting? So let's say someone comes in with chest pain. You ask them what was the onset, or like when did it happen? Where does it happen? How long has it been happening for a duration? Characteristics, does it feel like stabbing chest pain, or does it feel like more so a dull, achy pain that stays there, or it was persistent? What aggravating means, are there things that you do that make it worse? Like, for example, someone's having shortness of breath, maybe it gets worse by walking or jumping or running, so you'd want to ask that. And also relieving, is there anything that the patient has done to make it feel better? So for example, if someone has vertigo, usually it is recommended to lay down on your side, or in a fetal position. That might relieve pain, or feeling of dizziness or abdominal pain. The timing, for example, like when did it start? Did it start 2 hours ago, 3 hours ago? Has it persisted since then? So again, these are all the questions. Always ask questions, right, for the patient if you're not sure. And then severity, like you would define severity on a pain scale of 0 to 10, and you need to define what does 0 mean, what does 10 mean. From a 0 being, no pain at all, or 1 to 10, as in the smallest amount of pain, to 10. And one of my preceptors has taught me, like, this, if the patient's not sure what 10 means, to say like, oh, like you've been hit by a bus, like the most severe pain you've ever felt in your life. Because sometimes I've been asked by a patient, like, how do I know if it's the worst pain I've ever felt in my life? So, you want to say, oh, like you've just felt like you've been hit by a bus, or like the most severe pain being 10. All right. So now I've talked a little bit about HPI in depth, but basically we also want to gather the past medical history, including childhood, adult, current illnesses or previous illnesses, any immunizations, past surgical history, PSH, like what was when did they have that surgery? What was the outcome of the surgery? For example, maybe let's say someone had a fall, okay, and they had a previous knee replacement. And so if they hit their knee, you want to be able to make sure, oh, okay, like if that was at the same knee that was replaced, because you want to make sure that the hardware has not been impacted by that trauma. Any prior hospitalizations, you want to know different hospitalization history. You want to know family history. Does anyone in the family have, let's say, heart issues? Anyone with hypertension, if someone has hypertension or diabetes, because there are a lot, our genes really affect a lot of our illnesses. What their medications are, this is very important. Not just the names of the medications. Now, not every patient would know their names of the medications, but tend to know. They can just, sometimes they describe like pill sizes, pill colors. Oh, the yellow pill I take once a day for my stomach, and that's very vague. You want to try either reviewing the patient's chart, because sometimes they may not know what medication that they're taking, or if there are a lot of them, honestly, even I wouldn't remember all my medications. So often patients come in with medication lists, or their family members might know if they're with them. And also you want to be able to know the route, like if it's IV, intravenous, or oral, or oral with a pill, IV. And you want to know the dose, is it 50 milligrams or 20 milligrams? That's how you're able to sort of assess like how the patient is being treated. Because again, if this is the first time you're seeing a patient, you want to be able to, you want to make sure that you're not missing anything. And so far I've only talked like this, basically this entire section, this is all history taking. So this is something you learn in the first semester of medical school, so why not get a head start? You also asked about social history. Who does the patient live with at home? Do they work? Are they retired? Any recent travel that they've had? You tend to ask that if you're suspecting like an infectious disease. Pets, any relationships, and past sexual history. And then you sort of, sometimes people are a little bit nervous about asking these, but you just have to ask them maturely and ask it the same way. And you can also preface it before asking the patient, like, okay, I'm going to be asking you some sensitive questions. Is it okay if I ask you? If they have visitors or family in the room, you'd want to ask, are you comfortable with me asking with your family in the room, or would you like me to ask or request them to kindly leave? So it's up to the patient. You want to make sure that they are comfortable. You want to ask about their diet, exercise, tobacco or smoking use, alcohol, if they have any illicit or non-illicit drugs, and also their sexual history. That is the entire history of present illness and history taking. And finally, also, most importantly, or not, last but not least, I mean, not maybe not always the most important, if this patient has any allergies, that sort of concludes the history. So everything I've outlined with the pink marker and above, that is all my history. Now, ROS stands for Review of Systems. This is sort of the next phase of history taking. You want to ask them, okay, so you come in with these symptoms. Let me ask you these questions. Have you felt any weight loss or pain in the last, in the last few days? Do you have any fever, chills? Yes or no, right? Have you had any changes in your sleep patterns? Yes or no. So I tend to just go through this as a checklist. I check off whatever is relevant. You will get a lot of, these are yes, no questions. So there's not much repo building to be done here. Then you move on to the next page. You can see here any additional notes you want to be able to take. And then finally, you want to get to the physical exam or the actual data collection phase. You can see here the blood pressure, pulse, respiratory rate, temperature, and then also O2 saturation or oxygen saturation, their weight, their height, and BMI. So, and now technically weight, height, and BMI are not technically part of the vitals, but they are part of the physical exam. And then what basically I would be pretty confused. Like, what is the difference between review of systems and what is the difference between physical exam? So review of systems is what the patient reports. And then the physical exam portion is what I, as a clinician with my decision-making capacity, is able to figure out once I perform different types of maneuvers or physical exam functions. Like there are different types of physical exams. There's abdominal physical exam. There is a neuro exam where you're checking all the different types of nerves. I know we've talked about the neuro exam before. The mini mental status exam. You want to check overall. There's also a head and neck exam. The respiratory, of course, you can check the lungs. Yeah, I'm sure you've had that. When the doctor says, that's when they're actually like analyzing you after they collect your history and talk to the patient. All right. I think that goes over sort of in brief. After that, you have your labs and imaging, and it's just a problem list. But I'm still learning that right now as a student clinician. So we'll move on. But basically, this is the best. I would say that this is basically first year of medical school, and then we're slowly and surely learning how to analyze different labs, what labs to order, what imaging tests to order based on the patient's history. I know we talked about this in January 2024, actually. 70 to 77% of the patient's illness or disease can be found or deduced from learning the patient's history. The rest, like labs, imaging, you use that to confirm the diagnosis, not necessarily most of the time. Of course, there are exceptions to this rule, but you use that to confirm diagnosis. All right, now let's get to our case studies. Now that we have all that toolkit, we have the tools that we need, we have a bit of clinical understanding and knowledge. Now let's actually see patients. Let's say we're in the hospital right now. So we have here Mr. Thompson. This is a made-up name. A 45-year-old male who has reported chronic symptoms of gastroesophageal reflux disease, or GERD, that have progressively worsened over the past 5 years. Okay, so what should we ask next? I would have to say, uh, okay, so I would have to say that next we should be asking questions, right? Of course. I would want to ask what symptoms specifically has this individual been experiencing, right? Because symptoms is pretty vague. So I'm coming in, I'm knocking on the door. Hey, can I come in, Mr. Thompson? Hi, my name is student Dr. Minahil. I am here to sort of ask you some questions and gain a better picture so that I can talk to the physician, or if I'm the physician, by then, I would ask more questions. So first, I would want to ask through my history of present illness. That's the first step, HPI, that we talked about. And again, onset, location, duration, characteristics, aggravating, relieving, timing, and severity. Like I would probably ask, like, what symptoms has this patient been having as well. So one mnemonic that I learned to remember every component of my HPI is old carts. That's just been very helpful. And then basically the first letter of every word essentially has the as you can see, the C for characteristic is here, and and this is just the order. You can have all these things, and you don't necessarily have to have the correct order, but as long as you have all components, it's important. So because it forms the word old cards, that's how I'm sort of organizing it in my head. And then I asked, Mr. Thompson, do you have any prior surgical history? Do you smoke? Do you drink alcohol? And so he reports to me and says, okay, yeah, I drink alcohol socially on the weekends. Now, I would also want to ask a follow-up, like how much alcohol do you consume, like and what type? If I want to get into more specifics, because different types of alcoholic beverages have different types of blood can lead to different types of blood alcohol concentrations in the blood. All right. And then I also asked, of course, I think so, it's supposed to be the first, this should have been first, right? Like, what symptoms have you been having? So he said, I've been having persistent heartburn, acid regurgitation, and also difficulty swallowing, which is called dysphagia. Okay. So I know the significant past medical history, GERD, and I'm seeing that this patient has some acid regurgitation and some difficulty swallowing. So let's actually move on and let's think, what else do I need in order to help this patient? I can give you a hint. This is part of the physical exam component, the objective component. Correct. We need more data. We need more data in order to understand what's going on. So you can see here, again, I'm revisiting my handy dandy tool, my HPI tool that we are all super experts at. And let me all right, yes. So right now we're here. We are going to get more data. I want to get the patient's vitals. I want to probably get some labs, stuff like that. Okay. Now, in order to basically, now that I'm doing my physical exam, let's say I'm going to be talking to you a little bit about the patient's clinical presentation and my diagnostic approach to approaching this patient who has GERD, and also someone who has been having some increasing clinical manifestations and symptoms. So I try to do a physical exam. I listen to their lungs, to their heart to make sure that I can rule out anything else on my differential diagnosis list, to make sure I'm not missing anything. And I'll order some labs. The labs that I ordered were CBC, and also I found in their blood that there's elevated serum bicarbonate, and elevated serum bicarbonate in the event that there is a normal CBC. That would reflect that there is a chronic acid-base imbalance or disturbance due to the acid reflux. All right, and so now I want to know, what are my next steps? Now that I have a bit of a diagnostic understanding of what's going on, my next steps would also have to be to sort of I want to see the esophagus, because it's a little bit weird. If for 5 years, this patient has had worsening symptoms, I want to be able to actually scope. It's called scoping the patient, which is just short for performing an endoscopy for the patient, and also do a biopsy of the tissue sample from the lower esophagus. So I'll show you the findings on the next slide. But before I do that, I want to show you what exactly is an upper endoscopy. Basically, it is a procedure performed by a gastroenterologist. A gastroenterologist is someone who is board certified in internal medicine. They did their internal medicine residency for 3 years after medical school, and then an additional 3 years of fellowship training to become a gastroenterologist, or specialized in basically all in gastroenterology, which is the study of the digestive system. So here you can see the patient is being scoped. There's a screen over here where you can see that that's where the clinician is able to actually visualize what's going on. And actually, this is how it would look like in real life beyond just the clip art images. So basically, the patient would be under sedation, so you don't really feel this. And this is how the clinician or the gastroenterologist is currently visualizing the patient's esophagus as they go down that long tube. Again, the gut is really just one really long tube from the mouth all the way to the rectum, which I find really fascinating. So now let me show you the endoscopic findings and also the histological confirmation of what I'm thinking right now in my differential. So again, the histological confirmation, why did I do a biopsy? Why did I want to take a piece of tissue? Because I want to use that to confirm, not to confirm a diagnosis that I'm thinking of right now. And remember, this patient has been having acid regurgitation. That means that that lower esophagus has been being hit by more and more acid. So I'll show you now what the gastroenterologist saw. So what they in a healthy patient, what you would expect to see here is this normal lower esophagus. This is normal. But in Barrett's esophagus, this is what they would see. This is what they would see. It's a different type of tissue, right? So that is a metaplastic change, right? From metaplasia. So that is because the intestinal cells have sort of perforated up from the stomach because of the acid in your body wanted to adapt in order to handle that acid. That video I showed you, you can see here even at the bottom, the Barrett's esophagus looks like this and in the darker pinkish color, and normal squamous epithelium looks a little bit lighter and pale in color. So I think that's so very fascinating because we're able to see a clinical manifestation connected to metaplasia, right? We're just talking about cells. So the gastroenterologist would look for areas where the normal pale pink squamous epithelium of the esophagus transitions to this red velvety mucosa. That's indicative of columnar epithelium. So these areas are usually very well demarcated, as you can see here in the top panel in Barrett esophagus. It's easy to see and visualize down there. This is not something that you can see on a chest X-ray though. All right. Yeah, and here's another example of essentially the normal esophagus, the normal squamous epithelium, and how it changes into the metaplastic columnar tissue. Because of that gastric acid reflux you can see on the bottom due to inflammation or injury, or just because, or in our case, our patient had GERD, right? That is indicative, that history. Now let's look at the histologic findings under a microscope to confirm Barrett esophagus, because I see the clinical manifestation. Of course, a gastroenterologist will be able to diagnose this, but just to confirm, I did the biopsy just to confirm as well, and the pathologist would send out the findings that when you compare. Now I included the normal ones that you were able to compare normal to abnormal, but you can clearly see that there is a significant difference in the types of cells on the left versus the right. On the right, you can see that there is a change in the type of cell. Remember, to which type of cell? Which type of epithelial cell? From squamous to columnar. Here's an example again, the squamous epithelium in normal esophagus to a columnar stratified epithelium. And they look like little, basically little rectangles. And these are the stem cells that produce these different types of cells. So remember, I said before, metaplasia can only occur in areas of the body or organs that have stem cells. That would not include the cardiac muscle, it would not include muscle cells, or it would not happen in neurons either. All right, now let's actually very briefly go over the clinical management, because I wanted to mostly go over the diagnostic finding and the application in clinical medicine from that description of growth adaptations. So really, I'm just giving you a very, very bird's eye level view of how you'd manage Barrett's esophagus. Now, fun fact, there's no cure for it, but it is able to be managed, right? So number one, you'd want to advise the patient to avoid foods that trigger the reflux.
Okay, Minahil, I have a question for you. So you
Yes.
said management. So as you mentioned, there is no cure, but we can manage. Manage what? What are you
Manage.
managing here?
You'd want to manage the symptoms, right?
Very good, very good.
You want to
So
manage the symptoms.
why do we need to manage the symptoms?
The reason why, that's a good question. The reason why is because because if the Barrett's esophagus is not managed, it would lead to the development of esophageal adenocarcinoma.
Right.
So it can
No.
worsen, the metaplasia can be a precursor to dysplasia, which is precancers, and then finally to cancer and
Right.
carcinoma.
Right, definitely. And also the reason we are managing the symptom to improve the quality of life, right? So like we don't have a cure, so we are managing the symptoms. So there's a reason we have to make sure, of course, diagnosis is very important. And then, of course, face history, as Minal mentioned before, then diagnostic steps. And this is the beauty of internal medicine, that you see all kind of cases from head to toe. So whenever gastroenterologists do the endoscopy and they send us the report, so it's so fascinating to see. You have, all the care of the patient, each and everything about your patient, what's going on. So like if I refer this case study to gastroenterologist for endoscopy to help us with the diagnosis. So this is how I really like the internal medicine, that we can manage head to toe, and we in touch with the consultants, and we have provide all care to our patients. All right, thank you, Minahil. Yes, please move on.
Thank you, Dr. Shimon. I think that brings up a very important point where it's not just one doctor working on this patient because the physician has referred this patient to see a gastroenterologist to get scoped or an endoscopy done. And also, if that gastroenterologist does a endoscopy with biopsy, then the biopsy is not being read by the gastroenterologist or the internal medicine physician. That biopsy is being read by a pathologist, which is another type of specialty, right? So there are already three specialties just from this one case that are working together and communicating with each other to ensure that this patient has the best possible care.
Right.
So
Yeah. So that's how you can see how important pathology is, right? So that's the reason in a medical school, we learn the normal physiology, anatomy, then we go to pathophysiology. So that's how we get all the over view of everything, how it looks at under the microscope, how gross anatomy looks like, what's the physiology. When we know the physiology, then we know the what's the pathology, what's wrong with that, right? And then diagnostic, of course, pathologists, they do they have training, they have residency training as well, 4 years, and then they do specialization as well. Some do the breast, some do the different areas of pathology, and then this is how the surgical pathology, they do look up all the surgical specimens and diagnose. And then after the diagnosis, then we see how to manage, right? So that's very important. You brought this up. Yeah. So now gastroenterology, after internal medicine, you can do 3 years of fellowship in gastroenterology, and pathology is completely separate. So that's the reason we have to learn all the gross anatomy, physiology, pathophysiology. So now, I mean, I have a question for you. So I'm going to quiz you pretty quick. So what's the normal epithelium of the esophagus?
it is squamous epithelium.
Very good. And so what happens when there's a better esophagus? So what's the epithelium in squamous epithelium? I mean, what's
It'll
the
change to a
Barrett's esophagus?
it'll change to a columnar epithelium.
Very good. All right. Awesome. Good. So that's the reason, I'm trying to reinforce, like you can get a question in your USMLE, step one, sometimes step two, the clinical scenario, case studies, and then ask you what was the change. And so they give you different types of epithelium, and then you have to know what's the diagnosis, how do we diagnose Barrett's esophagus. All right. Good. Let's move on.
All right. Thank you so much, Dr. Shimaina. That's very helpful for me and also many of the students listening in. So basically, like I said before, the clinical management of the symptoms of Barrett's esophagus, because it is an important, why do we want to manage it? It's because Barrett's esophagus is an important risk factor for the development of esophageal adenocarcinoma. So first and foremost, you would want to start a more aggressive PPIs or high dose proton pump inhibitors because this patient already has a past medical history or chronic history of GERD. Maybe they're already on PPIs such as pantoprazole or omeprazole, and you might want to increase the dose of it. That's why I said you need to know the doses of the medications when you're collecting the patient's history. You'd also want to advise the patient in diet and lifestyle modifications. Like you could advise the patient to avoid foods that trigger the reflux, like caffeine, chocolate, spicy foods, other types of fatty foods. Stop smoking if they are smoking, but here our case, our patient is not a smoker. Limit the alcohol consumption. That was significant in this patient's history. They do drink alcohol. Lose weight if overweight, and avoid lying down immediately after meals. That will help reduce just through the lifestyle modifications, the amount of acid regurgitation that this patient is experiencing. So we want to be able to address all these holistically for the patient. Next, you'd also want to ensure that this patient is having endoscopic surveillance regularly. So the guidelines specify that that basically if during this endoscopy that in the report, if the gastroenterologist did not see, or the pathologist did not see dysplasia cells, like did not see dysplasia, and that means that the Barrett esophagus is sort of well controlled and it has not progressed to cancer yet. That means that the recommendation would be to do the next endoscopy after 3 to 5 years. It depends on the clinical symptoms and management. Now, as the internal medicine physician, you'll be able to see this patient for this number of years and make sure that they're getting their endoscopies on time and when needed. And you're able to adjust this plan based on the patient's symptoms and based on with the medications, with the diet, with the lifestyle modifications. If the symptoms improve, then you can do your endoscopy after 5 years, even the next one, just to make sure that it's being watched. Because like I said, this is an important risk factor for cancer. If there was dysplasia seen in this endoscopy biopsy by the pathologist report, then the guidelines recommend to basically have another endoscopy after even as little as 3 to 6 months. So really, or even a couple of months, basically, because you want to be able to keep watching it and start the treatment for cancer. Now, we are going to be talking about principles of neoplasia or cancer in our next session. All right.
Right.
Now,
So Minal, let's go back a little bit. I have a few questions to explain further. So I really appreciate. So as you mentioned about the PPIs, so proton pump inhibitor. So do you know the mechanism of action of proton pump inhibitor? If not, I will elaborate and explain to you. So do you know the mechanism of action of proton pump inhibitors? The reason I'm
so
bringing this up, because over here now it comes the pharmacology. So pharmacology, like any medicine we read about, we give them to the patient, we have a side effects as well, right? So if we know the pharmacology, we know the mechanism of action, what are the side effects, because we have to explain to the patient as well, right? So that's the reason I'm bringing this up. So mechanism of action, can you tell me briefly what is the mechanism of action of PPIs?
basically, they basically stop the stomach's ability to produce more acid. That will reduce acid regurgitation. Now, specifically, mechanism action wise, they prevent the hydrogen proton pump, ATPase pump itself. So if they're stopping that pump, then that will reduce the amount of protons being produced, which ultimately leads to less acid.
Sure. Yeah, I will add on is a hydrogen potassium ATPase pump on the parietal cell membrane. So to be specific, yeah, you're right. And just how the PPI works by binding to and inhibiting the hydrogen potassium ATPase pump on the parietal cell membrane lining, and which prevents the gastric acid secretion. So that's the reason we learn about biochemistry, organic chemistry in our undergrad years. So I'm trying to reinforce the importance of biochemistry. You know, it's a very tough subject, right? Most of us feel like, oh my God, it's a really a brain teaser, but you know why we need to learn, okay? So that's why I'm bringing this up, the pharmacology, what's the mechanism of action, what are the side effects, how PPIs work, and main reason is we have to reduce the gastric acid production. And that is the hydrogen potassium ATPase pump, and lies where it resides on the luminous surface of the parietal cell membrane. Okay, good, very good. And also, pretty quick, I'm going to talk about the second point, the diet and lifestyle modification. So again, as in the beginning, I just went briefly about the self-care, right? So self-care is all about lifestyle modification. It's all our habits, right? So dietary modification, what we're supposed to do, it's our habits. I always tell my students, habits make us, habits break us, right? So diet, always try to have a healthy diet. Don't think that we have to wait. Of course, this is for counseling, for educate the patient about diet, lifestyle modification, but also apply in your life as well, right? So you have to keep check what you're eating at healthy diet, keep an eye on your calories count, and make sure your BMI, because the body mass index is a weight based on your height, is according within the range. And because you have to be very careful with your diet as well. And lifestyle modification, what it can be, right? Exercise, we talk about sleep hygiene, stress management, and you will, with some time, we'll learn about the stress ulcers in the stomach. Why? Because we don't learn how to cope with our daily routine stressors. So it's very important to learn. So whenever we talk about the self-care, so these are same, if we are, like, we have to walk our talk, right? So when we educate our patients, like if I'm obese and I'm educating the patient about lifestyle modification, so do you think patient will take my advice, right? So patient, that's a very important, that why I bring this up in every session about self-care, importance of self-care, and then work on all the 4 areas. All right, so let's move on to our next case. Let's do it together, Minahal. Let's move on. All right, so our next case study is a 61-year-old female with past history of significant for hypertension, presenting with shortness of breath, fatigue, and occasional chest pain. So what do you think? What should we ask next? So this is, we are talking about history taking. So patient presented with these symptoms. So what we are supposed to do? So let's, Minahal, let's go over. I will ask you. So you tell us, what do you think? What is all detailed history? Because as I mentioned before, patient give us the diagnosis. So be patient, Ask the patient all the details. Don't rush the patient. Don't interrupt the patient. And ask very direct to patient if patients are going too much detail. So we need to learn how to take a appropriate history in a specific time. So it will help us. And I always tell all my students that patients give us the diagnosis, what's going on. All right, I'll stop here. So let's move on.
Thank you, Dr. Shima. That's very true. I think that we do definitely, I think I was talking about before, the statistic is that we get about almost 70% of the time just the diagnosis just from the patient's history provided by them. So in that clinical deduction reasoning, basically, we go over the HPI with the patient, right? We want to be able to understand when this happened, when this fatigue started happening, and also the occasional chest pain. But I wanted to point out a very important question here. I want to ask this patient. Now, also, this can also lead us to social determinants of health. But if this patient is might say, if I hear this, and remember, this is why listening is so important. If the patient says, "Oh, I wasn't able to pick up my meds from the pharmacy," or "I'm not able to afford my medications," or "my insurance was cut off," or something like that, that means that this patient is not able to, now we're sort of getting away from the word non-compliant to non-adherence, because non-adherence is more inclusive of the different social determinants of health, because maybe this patient is trying to comply with the medication regimen that's been prescribed, but they're just not able to adhere to it, maybe for various reasons. Maybe they don't have transportation to get to the pharmacy. Maybe they don't, maybe they're not able to afford it. Like I said before, maybe they don't have insurance coverage. Maybe they're just having really bad symptoms from or side effects from the medication that's preventing them from taking their medication. So when I did ask this female, this 61-year-old, let's call her Miss Janet, I asked Miss Janet, are you taking your prescribed, let's say metoprolol, for which is a beta blocker for your hypertension? And she says, well, I'm trying to, or I'm not able to for any reason. And that will make me think internally, okay, is this hypertension being well controlled? Because that means I need to be able to also get her blood pressure. Of course, we're always getting the vitals of every patient, but I would want to keep an eye out for that blood pressure and see, because of the significant history of hypertension, if it's not been well controlled for a number of years, it can lead to worse changes in the heart. Remember, I was talking about this before. If there's too much blood pressure on the heart, just from a layman description, it will cause the heart muscle to hypertrophy. It will increase the size of that muscle, and that could be causing that shortness of breath, the fatigue, and the occasional chest pain. So again, we need more data. Like I said before, we need the patient's vitals. We want to do a full workup, a full labs. Just because I have this one idea in mind doesn't mean that I have ruled out my other differential diagnoses yet. I want to be able to confirm what I'm thinking so far. So we need vitals, labs, and also an ECG and also an echocardiogram. I want to be able to see this patient's heart, visualize it, and also see the electrocardiogram. So I highlighted in yellow the initial diagnostic findings. So let's say this patient came into the emergency department, and if and when I remember when I was shadowing my emergency medicine physician, these are always the initial diagnostic findings. These are the more faster workups, in fact, because they lead to faster results. Now the ECG also comes really fast, but for example, like if you want to get a chest X-ray or an echocardiogram, those take a little bit more time. So in the meantime, we're not just going to wait for those because that might confirm my diagnostic suspicion, but I also want to make sure I'm not missing anything. Like if this could be a heart attack, of course, we want to be able to see if their troponin levels. So in yellow highlight, we can see here the elevated blood pressure of 160 over 100 milligrams mercury. In the BMP, or the basic metabolic panel, because the CBC is normal, I see a creatinine is slightly elevated. I see the BUN is slightly elevated. Now creatinine being slightly elevated could mean that there's some renal dysfunction happening, but it is slightly elevated. So we'll not ignore it. We'll keep that in mind. We see that also the glucose is incredibly elevated at 180 milligrams per deciliter, and also the HbA1c is 7.8%. Now, I did not give you the full past medical history of this patient, but this patient also does have diabetes mellitus type 2. So clearly, I'm seeing, okay, maybe there might be a social determinant of health issue, because it may not just be that one medication, metoprolol, that they're not able to have, but also perhaps they're not able to have their insulin, they're not able to have their metformin or other diabetes-related medications. All right, so those are my lab findings that I get within, I guess you could say, within the first hour of the patient being in the ED, the emergency department. Now these are my electrocardiogram findings. Now you can see here, first we know the heart rate. Even if you're not able to read the ECG does also tell you the heart rate, which we also have from the vitals. The heart rate is elevated. There is tachycardia with a rate of 102 beats per minute. The rhythm is regular sinus rhythm, but the voltage criteria there is a high voltage, there are high voltage QRS complexes in the left-sided leads that actually indicates something called LVH, left ventricular hypertrophy. There's also repolarization abnormalities because there's like now remember the PQRST waves. The PQRST waves actually I should have had like a normal ECG to compare this with, but basically this is an abnormal ECG because it should be they should all look like what's here, what I'm pointing at here. Whereas this is the left-sided leads. This is what I'm referring to. This is a little bit, these are abnormal PQRST complexes. So the PR interval is normal, but the QRS duration is slightly prolonged at 110 milliseconds. So that reflects actually delayed left ventricular conduction. So there's some issue happening with the electrical signaling in the heart. So that means that there might be some, it could be for a variety of reasons. So that's why I already see these results. I also want to, now I also eventually got my chest x-ray as well. That's the next fast workup that I can get. Now I see here that, now here I included normal versus abnormal. And essentially here you can see, 1 second. Okay, so basically you can see on the right, there's cardiomegaly on the chest x-ray here. The cardiomegaly means an increased heart size. This is normal on the left and abnormal on the right. So the cardiomegaly can happen for a variety of reasons, but it looks to me right now that the systemic hypertension that was poorly controlled might have led to an increase in size of the heart because it's been working so hard. Looks like the best analogy I can give you is your skeletal muscles. If I keep working out this right arm, but I'm not working on my left arm, my right arm will be more muscular, more jacked. So that is cardiomegaly in an essence, right? If I keep overworking my heart, it'll increase in size, and that's abnormal. That's not a good thing. That's why it is so important to make sure that you are following your medication regimens with high blood pressure because you want to prevent this from happening. Now, this is an example of a normal echocardiogram. Let me actually get my pointer out. All right, so this is the left ventricle. Now, remember the heart has 4 chambers, right? There is the left ventricle, right atrium, and left atrium. Remember the blood flow of the heart, it starts off, if I am remembering correctly, it starts off like basically the blood flows like this and into the lungs to get oxygenated into the lungs, and it comes back. So, but we'll get into this during cardiology month. So this is the apex of the heart. So basically we're looking at the heart upside down. So if this is the heart right side up, this is the heart upside down because that's sort of how echocardiograms look. So we know that left ventricle is here. And if we are already suspecting left ventricular hypertrophy.
Okay, Minahil, I would like to add on here. So you mentioned about something about left atrium or right atrium?
We're talking about left ventricle.
No, before that, you said the venous blood comes from superior vena cava and inferior vena cava in the right atrium. And from the right atrium, it goes to the tricuspid via the tricuspid valve to the right ventricle. And from the right ventricle, it goes to the lungs. And from the lungs, come back from pulmonary veins to left atrium. And from the left atrium, goes to the mitral valve to the left ventricle. And from the left ventricle, it goes out throughout all our, first of all, arch, then all the aortic branches. So this is how we get the oxygenated blood from the left ventricle.
Thank you, Dr. Chima. I know I forgot this is also on MCAT, like the flow of blood from deoxygenated blood all the way to oxygenated blood. So thank you so much, Dr. Chima, for the refresher. All right, so this is a normal echocardiogram. This is not the echocardiogram of our patient case, but these are the results from our patient case. So here I labeled here. So you can see here, this is the left ventricle. This is the left ventricle. Do you notice a little bit of a change here? It's a little bit, usually these are symmetric, the right ventricle and the left ventricle, but you can see here, the left ventricle is a little bit increased in mass, right? So if I go here, and I see here, if I also included the same screenshot from the last slide. If I want to really just compare it side by side, you can see here that the left ventricle is much bigger than the normal left ventricle size that you would expect in a normal physiologic patient. So here, the left ventricular wall is increased. So there is hypertrophy that is evident. The EF, or ejection fraction, is 55%. This is also something that an echocardiogram tells you. This is within normal limits, but it is on the it's on the lower side of normal. That could also be why there might be some chest pain, shortness of breath. The left atrial size, it's also mildly enlarged as well. So this left atrial size also a little bit large, and increase in size. The valvular function is also saying that there is mild mitral regurgitation. So remember, our mitral valves are here. So that means that the left side of the heart, there's something wrong. There's something going on. So now that we have basically confirmed our diagnosis of left ventricular hypertrophy, remember we talked about hypertrophy. What causes hypertrophy? What is the physiologic explanation of hypertrophy? Remember, increase in cell size, because the cells are trying to adapt to the poorly controlled hypertension, the systemic hypertension that has led to this clinical manifestation or this clinical pathology. So again, this is what pathologic hypertrophy looks like. On the right is a normal left ventricle. On the left, you can see here, it's the heart muscle is expanded so much more. In normal cells, these are cardiac myocytes, cardiac cells. So cardiac myocytes, they don't increase in number. This does not undergo hyperplasia. This is called hypertrophy. You can see here that the size, the width of these cardiac myocytes are almost double. Almost, really, it is double the size than normal if you look at it under a microscope. All right, now this is our final case for today, case number 3. And Dr. Chen, would you like to read it for us?
Yeah, go ahead.
Okay.
So case study 3, yes, please go ahead, and we'll see.
Okay, so case 3, an 81-year-old female hospitalized for several weeks for management of chronic heart failure presents with significant muscle wasting upon discharge from the hospital. So this is a different type of case. This patient has been managed in the hospital. And 1 second, I'm having technical difficulty. Let me reshare my slides. 1 moment. Let me reshare my slides now before I start this case. There we go. Everyone can see my screen again. All right. So basically, let's say this patient's name is Miss Evelyn. So Miss Evelyn, who has a history of chronic heart failure, she was managed with medication. She was initially hospitalized for, let's say, acute exacerbation of heart failure due to a respiratory infection. But during her hospital stay, she actually underwent, well, actually, I'm talking to you about basically the patient's hospital course right now. So during this patient's hospital stay, she developed complications that required intubation and mechanical ventilation for 2 weeks, which led to prolonged bed rest. This is very key. A long time laying down. So post-extubation, our patient, Miss Evelyn, remained mostly bedridden due to weakness and decreased mobility. So the duration of stay, the patient was initially admitted for 4 weeks due to the complications, including respiratory failure and subsequent heart failure management. There were also some hospital complications, including this patient developing ventilator-associated pneumonia, which extended her need for mechanical ventilation, and that continued to contributing to the prolonged immobility or inability to basically, move around as she would. And so the medical interventions that were used throughout this hospital stay, this patient was treated with diuretics, ACE inhibitors, and antibiotics for the hospital-acquired pneumonia. It's a very common hospital complication. And gradually, this patient was weaned off the mechanical ventilation as her condition stabilized. So, and then finally, the initiation of rehabilitation occurred, right? So, Miss Evelyn, she initiated passive range of motion exercises like lifting the leg up from the bed, really, but not really able to ambulate that much. And so she had a couple of exercises done with physical therapy while in the hospital when she was stable. And then she was transferred over to this skilled nursing facility. Basically, the rehab goals at this skilled nursing facility, or SNF, that's the acronym that we use, SNF, SNF. Basically, the rehab goals included to focus on reconditioning and strengthening exercises to address the muscle atrophy. So here I'm giving you an example of atrophy. So far we've gone over the left ventricular hypertrophy, metaplasia with Barrett's esophagus, and this is an example of muscle atrophy. And remember, I talked to you about this before, where muscular atrophy is reversible. in theory. Now, of course, this patient is a little bit elderly. She's in the geriatric population, so she will need a little bit more physical therapy. I know I was giving you an example of me being in an airplane ride for 16 hours, but because I am relatively younger, I am able to just bounce back and adapt much better and reverse any mild issues I might have in my muscles as I stretch out. But here, the physical therapy regimen included active assisted exercises to reverse this muscle atrophy from being deconditioned in the hospital that progresses to resistance training, that's sort of physical therapy speak, and functional mobility training over several weeks in the SNF. So the progress in the SNF for Miss Evelyn, now the observations included her gradual improvement in muscle strength and function. So Miss Evelyn was able to begin to sit up unaided and later transition to standing and walking with minimal assistance. This is very good. This patient was able to restore her ADLs or active or adult daily living, basic living. So in total, Miss Evelyn spent 2 months in the SNF facility after being discharged from the hospital. She had steady improvement and active participation in her daily rehab exercises. So I'm going to talk to you a little bit about the mechanism of the of what happened basically to Miss Evelyn, right? So essentially, she had the extended bed rest that led to her muscles becoming atrophied, right? And in fact, this is very important to know that in a geriatric population, like 1 week in the hospital can lead to like a very, very, very like rapid muscle deconditioning. So this figure really shows you like the muscle atrophy is much more exemplified and spotlighted in an elderly patient. So if this patient was inactive for a long period of time, like several weeks, it can lead to accelerated bone loss as well. And also muscle weakness for many, many years. So it is important to ensure that if patient is able to be mobile during their hospital stay as well, and that will also lead to decreased bed sores. And really, this is all related to quality improvement because hospital-acquired pneumonia, that's an example of a complication. And so this muscle atrophy is also a result of trying to save this patient in other diseases. So really, there's this trade-off being done, whereas this patient was being treated for chronic heart failure, this patient unfortunately underwent deconditioning and unfortunately had hospital-acquired pneumonia and had to go antibiotics for that. That extended her hospital stay. So this is hospital-acquired, right? So we want to be able to improve the quality of care delivered in our hospitals as well. And so there are a lot of quality improvement teams that physicians are a part of in order to improve the quality of life of patients while they're hospitalized. So in turn, I wanted to also reiterate this point that if when you don't use something, you lose it. You don't use it, you lose it. So whether it be like dementia, right, or an Alzheimer's disease, there are so many studies done where if elderly patients, they do more crossword puzzles or they do many more like brain activity exercises, or they don't retire, or they're just continuing to use their brain at the same level as they did when they were 60 or 50 or 40, they have less chance of developing Alzheimer's disease, Parkinson's disease, or even having dementia, even with the family history. And also, as I was giving you an example before, effects of atrophy on the muscle, right? So atrophied muscle, if you're not using your arm for a long period of time, this is sort of why, like, because I'm right-handed, I would say that I have a little bit of a more muscular right hand than my left hand, right? Because I'm not using my left hand as much since I am right-handed. So with that said, we've gone over all the different types of cellular adaptations. I hope this was helpful for you all. Now this sort of concludes our session, and our quiz is now live to receive certification from this session on teleshine.com/certification. Like I said before, the next session will take place on Friday, May 24th, and we'll be going over the principles of neoplasia. Now, what happens after dysplasia, that precancerous item. And so what happens after that? That's very interesting. Neoplasia. Neoplasia means new growth or new disordered growth, you could say, in the cells, and how that leads to different various clinical manifestations in the study of oncology and also pathology, and also going over just the basic principles of pathophysiology that lay the foundation of our study for Clinical Pathology Month. All right, thank you so much, everyone, for attending, and we hope to see you at future sessions as well. Thank you, everyone. Take care. Bye-bye.